aim of the project, unfortunately, did come off the back of an SI incident. The aim of the project was to timely identify deteriorating patients and reduce the amount of cardiac arrests that we were having on ward C0. Firstly, we recognised that it wasn't all about the way that we were identifying the deteriorating patient, it was about how we were escalating it and getting the response that we needed from the doctors. So that's where we started basically, and it sort of snowballed then from there.
Big difference with a deteriorating patient on the ward, that they're seen in more of a timely manner. We can get a response time which has improved a lot since we've changed over to the bat and bleep system.
And we were looking at 1 cardiac arrest a month when we first started the project, and that's now been reduced to 1 cardiac arrest per 8 months. So yeah, very good outcomes from the project so far.
You can go into a patient and see that something isn't right. Even if the news is fine, you can know the patient. Or if you think when the obs come around, you think, right, okay, this patient doesn't look right, I'm going to put them as a priority and do their observations first, which makes you then act quicker and phone in outreach, phone in the doctors. If the patient is becoming septic, you can start a sepsis bundle, you can inform your nurse. You're saving lives. Our patients are not resulting in having something tragic as a cardiac arrest.
I think the main thing that we've had in the project, a consistent thing that we've had, is our healthcare support workers. They've not really changed from the start of the project until now. It does show it's increased. At the beginning of the project, we were heavily reliant on agency use. That's now reduced, but so we've got quite a novice team now. So it's just building up the confidence with the new team.
On the ward, we focused on our healthcare support workers because they were the ones who were doing the timely observations. They're the ones who got their eyes on the patients more than myself and the other senior staff. They're able to communicate with outreach doctors now, whereas before they would have been reluctant to pick up a phone and speak to someone senior to get a patient seen, but we've improved on that.
I was acting a lot more quicker. Outreach are recognising that as a healthcare support worker that you are concerned about the patient, and that if a nurse isn't ringing them, they kind of think, okay, this healthcare support worker has identified something, I need to go down and see this patient.
We had investment from the top end, really, with support with sponsors from the executive team, and we've had the QI team who've given us a lot of input, and they've been able to look at our data, to be able to have that time within the collaborative, to be taken out of your workplace to try and improve things, speak to a massive variety of people. Some of the workshops we did within the collaborative, with GPs, OTs, lots of other people, and how they work and how they try and improve their systems, of giving us insight to how we can try and improve our area. So we've looked at sort of introducing human factors into improving the culture within the wards, and using simulations to try and improve events when they happen. We've done some simulations of boarded patients and how we can improve for them to be seen in an emergency situation. We've
sort of focused on acute deterioration, but understanding that all the other health boards or all the other projects within the acute work stream have helped us recognise that there are different forms of deterioration. It's not just about the acutely unwell. So I think there's been a lot of learning there, and then that's potentially future projects that we could do then on the ward as well.